Hello, my name is Eva. I'm going to present the review of studies on effects of chlorhexidine bathing versus soap and water bathing on acquisition and transmission MRSA infections in a hospital setting. Methicillin-resistant Staph aureus has been identified in 1960s, and since then, the infection rate has been growing continuously in a hospital settings and in a community. The bacteria are not dangerous for healthy people, but those with a weaker immune system can develop serious conditions. Risk factors for acquiring MRSA include advanced age, antibiotic use, and prolonged hospitalizations. According to Noble 2009, approximately 85% of MRSA infections are connected to healthcare institutions. CDC report from 2011 shows that MRSA infections on ICU units increased from 2% in 1974 to 64% in 2004. Several studies conducted by CDC support the hypothesis that hospital-acquired MRSA infections are preventable. One of the studies conducted on a small population of hospitalized patients suggested that bathing with skin antiseptic reduces germs on patient skin, thus reduces transmissions of bacteria. Studies show that low concentrations of chlorhexidine gluconate used either in a basin in place of soap or as wipes reduces microbes on a patient's skin and is effective against MRSA infections. The study on microbial contamination in patients' bath basins when only water and soap was used demonstrate that 98% of the basins were contaminated with bacteria. The study assessing wash basins when CHG was used demonstrate that only 4% of the basins were positive for microbial growth. The selected articles were reviewed to address the following critical questions. Does the use of chlorhexidine solution or chlorhexidine wipes reduce the rate of MRSA infections in comparison to bathing in a basin with soap and water in hospitalized patients? The population of interest is patients who acquire MRSA infection during hospitalization. The evaluated intervention is the use of CHG solution or wipes in place of traditional bathing in basin with soap and water. The outcome is lower MRSA infection rate in hospitalized patients. CNOW and PubMed databases were searched for articles published from 2011 to 2016 investigating the effects of CHG bathing protocol versus traditional soap and water bath on MRSA acquisition in a hospital setting. The literature review was conducted to generate results and to describe an application of relevant studies to the nursing practice. Keywords used for searching included MRSA, chlorhexidine gluconate, and CHG bathing protocol. The studies were categorized according to their level of evidence. Each article was read to identify a type of study, key concept, sources, data sampling, methodology, and relevant findings. The search excluded evidence from systematic reviews or meta-analysis of all relevant randomized controlled trials or evidence-based clinical practice guidelines based on systematic reviews of RCTs. Opinion of authorities and all reports of expert committees were excluded as well. Out of 8 articles, 4 are Level 2 randomized controlled trials, 2 are Level 2 quasi-experimental studies, and 2 are Level 3 quasi-experimental studies. The presented studies have several objectives: to determine whether a daily bathing protocol with a chlorhexidine-based soap decreased MRSA transmission among ICU patients, to determine whether chlorhexidine-based soap bathing reduced overall Staph aureus transmission and ICU-acquired Staph aureus infections, to determine cost of CHG-impregnated washcloths versus soap and water bath basins, to compare bacterial colonization of bath basins, and to evaluate the adverse effects of CHG bathing. There are several limitations acknowledged in reviewed studies. This, from 2016 study, was conducted in a hospital that chose to participate in a study. The authors also were unable to assess compliance with CHG bathing protocols and bathing techniques. The limitations of study conducted by Patley included examination of only one bathing protocol and one product. There was also a difference in surveillance protocols on different units. In another study, personnel administering baths was not blinded by personnel evaluating for infection rate while blinding to the treatment. Bonacieri were not able to evaluate patients who were discharged before 14th day. One of the studies evaluated contamination of bath basins used for bathing patients. The study determined that both CAG and soap are equally effective in removing residual bacteria in comparison to water only. Bath basins with CAG showed zero bacterial counts on the surface, while basins with soap and water showed some bacterial count. The study concluded that CAG bath is more effective in removing bacteria, including MRSA, than traditional soap and water bath. 7 other studies evaluated the effects of CAG bathing protocol versus traditional soap and water bath on MRSA acquisition on respective ICUs. One study determined that CAG bathing reduces the rate of bloodstream infections, CLABSIs, and VRE infections, but it has no significant effect on decreasing MRSA infections. 4 studies found that using CAG-based soap is effective in reducing MRSA acquisition and transmission on intensive care units. 2 studies demonstrated that CAG bathing does not affect acquisition and transmission rates of hospital-acquired infections in a hospital setting. In addition, one of these studies concluded that CAG-based surface antiseptic reduces transmission of MRSA, but there is a concern that strains with QuAC-AB genes may be resistant or spread more rapidly. MRSA is a bacterium causing infections in the body, including sepsis, pneumonia, urinary tract, bloodstream, and skin infections. It's very difficult to treat because the bacterium is resistant to many antibiotics. MRSA is responsible for increased mortality and morbidity and cost of healthcare. The majority of studies demonstrate effectiveness of CAG-based products in reducing hospital-acquired infections, including MRSA infections. Chlorhexidine gluconate is an antiseptic effective against gram-positive and gram-negative bacteria. Using CAG in a bath prevents bacterial colonization on the skin surface, including MRSA. One of the studies pointed out that there is need for assessing patient skin for allergic reactions, skin irritation, dryness, and contact dermatitis. The skin issues should be addressed immediately to prevent skin break and potential infections. Also, nurses' responsibility is to educate patients and unlicensed personnel about acquisition and prevention of hospital-acquired infections, including MRSA. The emphasis should be placed on compliance with daily bathing. The support of care partners in implementing new intervention is crucial. One study recommends monitoring for bacterial resistors. Study by Petlin determined the cost of CAG bath to be slightly higher than traditional bath, but overall CAG intervention is both cost-effective and is beneficial in reducing MRSA infections. Because CAG wipes method takes less time than traditional method, a nurse can spend more quality time with the patient addressing other needs. The target population evaluated in reviewed studies is similar to the patient population on MedSurg unit. The findings can be transferred to my unit and successfully implemented. The concern is compliance, since our patients are used to traditional bathing and using wipes only does not have the same effect on how they perceive bathing. The patient population is large enough to justify the change in bathing protocol to benefit the patients. Most of the nurses on my unit are bachelor prepared, and the unit culture supports evidence-based practice. Because CAG baths are more time efficient, nurses would be able to focus on the interventions needed by their patients. As Patlin pointed out, using CAG wipes is easy, cost-effective, and does not require any special skills. The risk of not trying the innovation is patients' resistance to a change. Because majority of patients utilize traditional bathing, a change may result in non-compliance.